Hello, hello. And today we're going to start about dementia. We are going to talk about dementia. What is dementia? We all know what is dementia in the crude form, the different causes of dementia. If you ask any person, they're going to say Alzheimer's. But then what? After Alzheimer's, then what? And we'll talk a lot about this and we'll talk it really quick. Okay, we'll talk about it really quick. I intend on completing this lecture in another 10 minutes. Okay. So, first of all, what is dementia? Dementia is nothing but obviously there's going to be a major functional change. Okay, so there's going to be loss of uh, memory, all right, or there's going to be decreased recall in the crudest form, and also at the same time, so loss of memory, if I can write it, I shall write it, loss of memory. All right, dementia, loss of memory. But also obviously you will have a lot of different issues that could occur, like there's loss of learning. Okay, there could be loss of learning, there could be loss of language, social skills, sorry for that, language, social skills, etc. Okay, so there could be a lot of things. And see, the idea of this lecture is not to actually get into the very technicalities, because nobody is going to ask you that that what is dementia. We really need to look at it in the form of a clinician. Okay, so from the clinician's point of view, all right, first thing that we need to know is that the causes of dementia. So if someone asks you what is the most common cause of dementia, obviously Alzheimer's. That's a no-brainer. But second, it could be a vascular cause. All right, they say it's a vascular cause. And third is the Lewy body dementia. And fourth, if you are really interested, is NPH, normal pressure hydrocephalus. Okay, so far so good. Also in HIV patients, you would obviously have something called as HIV associated dementia, and we'll get into that. Before we get into dementia, there is certain things that will actually make the entire topic very easy for us. When I look at dementia, I look at dementias as three different group of disorders. First is a tauopathy, second is an alpha synucleinopathy, and third is the vascular dementia. Okay, and then obviously your NPH, and now I can add one more, HIV associated dementia. But majorly I need to look at these three, okay, because these three have the most common causes of dementia as well. So tauopathy is the one that is associated with Alzheimer, so that is something again you should remember, that Alzheimer has a tauopathy. Second tauopathy that you should remember is FT dementia, that is frontotemporal dementia. However, it is not one of the most common causes. It was definitely a good question to come up on exams. Then we have alpha synucleinopathy, which is a Lewy body dementia, and then we have a vascular dementia that we also think that it's one of the second most common causes of dementia. All right, without so since I have now given you the entire breakup, that obviously tauopathy is your Alzheimer's or frontotemporal dementia, alpha synucleinopathy is your Lewy body dementia, and vascular dementia is another entity as such, let's directly use this classification to get into one of the most important causes of dementia, that is Alzheimer's. So let's talk about Alzheimer's. ALZ is basically Alzheimer's. I hate writing the entire form. Alzheimer's is what? Alzheimer's is dementia as the most common cause of dementia, and it is associated with increased age. Obviously, as it is associated with increased age, it's associated with more in males than it's associated with more in females than in males. Remember that. Okay, Alzheimer's is associated more with females. Okay, there is a very important association that it has with ApoE4 and ApoE2. E4 is the one that if increased causes increased risk, and ApoE2 if decreased causes decreased risk. Okay, so ApoE2 is your good one. Okay, so I'm gonna double tick it. ApoE2, you should have ApoE2. It decreases the risk of Alzheimer's. But ApoE4, as the gene ApoE4, which is present on chromosome 19, it increases the risk of Alzheimer's. Also, very important association is with the Down syndrome. Okay, so the Down syndrome is a trisomy 23. So I write trisomy 23 as 23 cube. Okay, so trisomy 23. What does the chromosome 21 actually have? The chromosome 21 has a very important gene called APP. What is APP? APP is a very important gene that codes for amyloid precursor protein, and this amyloid precursor protein actually forms an amyloid. Okay, now this amyloid is of A beta is of A beta variant, A beta amyloid. And A beta amyloid is of two types. Okay, now we're getting into the crux of it, okay, slowly and steadily. So A beta amyloid is of two types. One is A beta 40, and the other is A beta 42. I want you to remember that 42, A beta 42 is the one that's associated with Alzheimer's. A beta 40 is associated with cerebral amyloid angiopathy. This could be a potential question because of the fact that A beta 40 is usually considered as the only cause of Alzheimer's, and we do not dig deep into 40 and 42 differentiation. So just remember, 40 is associated with cerebral amyloid angiopathy, and A beta 42 is associated with Alzheimer's. Coming next is, obviously, that I've said that it has an association with Down syndrome, so it must be having other chromosomal association. So we have something called as a presenile, so presenilin 1 and presenilin 2. All right, so these two are very important with are associated with more or less with the early onset Alzheimer's. So you would have a patient who is around 40 years old or less than 40, in the 30 to 40 age group, and he's presenting with symptoms of Alzheimer's. He is presenting with Alzheimer's. So then you really want to dig into thinking that this could actually be one of the causes. Presenilin 1 and presenilin 2 gene associated early onset dementia. Okay, so that is another very important point that we've been making. And one more point that we must make is that Alzheimer's is also associated with a positive family history, correct? And it also has a lot of association with trauma and a little bit of concussions as well. So that's another important point that we can say, that trauma, concussions, any of these can actually exaggerate. So again, coming back, just to give you another quick and put it in a better format, is that Alzheimer's is associated with old age, is obviously associated with APP, which is on chromosome 21, is obviously associated with presenilin 1 and presenilin 2. It's also associated with those very important, as I've already spoken about, ApoE4. It is not associated with ApoE2. Instead, ApoE2 is more protective for Alzheimer's. A very important other association that we should keep in mind, obviously very, 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 very important, is that it's also associated with increase in female than in males. And a very important again point is that any history of trauma, concussions, or stroke is suggestive of Alzheimer's. Okay, once we've spoken about the Alzheimer's, I want you to understand the pathology of Alzheimer's. So, okay, let's get into the path of Alzheimer's. What is the path? As I said, it's a taupathy, correct? There were two taupathies. One is obviously your Alzheimer's. The other is going to be your frontotemporal dementia, or the Pick's disease, okay? So, we are looking into Alzheimer's. So, let's directly talk about it. So, what happens is that there's hyperphosphorylation. Hyperphosphorylation of what? Phosphorylated tau proteins, and these tau proteins are present, okay? These tau proteins are present in the neurons. So what are they going to form? Okay, so obviously the patho is associated with hyperphosphorylated tau proteins in the neurons. So it is a taupathy, correct? And they form neurofibrillary triangles. Okay, they form neurofibrillary triangles. Now, very important to note again is that it is also associated with A beta amyloid. It's associated with A beta amyloid, and this A beta amyloid forms neuritic plaques. It forms neuritic plaques, and these neuritic plaques are usually deposited in the neurons. Now let's look at the path. Let's look at the entire histology. Let's look at the histology of Alzheimer's disease. Obviously, first of all, hippocampus is going to be affected. Obviously, first there's also going to be cortical atrophy, okay, because of the neuritic plaques and the taupathies. Also, there's going to be hippocampus degeneration, which is why there is dementia. Another very important point is that there's going to be Hirano body. Hirano bodies are just eosinophilic proteinaceous rods. Okay, So we have cortical atrophy, we have hippocampus degeneration, we have Hirano bodies as the histology, and obviously neuritic plaques which are of AB amyloid, to be precise A beta 42 amyloid, and obviously your neurofibrillary triangles. So this is the entire histology when we talk about Alzheimer's. Now, what are the clinical features? Obviously, you will have dementia, memory impairment. Then you would have language involvement. Language involvement would be obviously of a nominal aphasia. Nominal aphasia is an aphasia that is, you have your fluency, you have repetition, and also that there is comprehension. So it's not the worst case of aphasia. Definitely it's much better, and it's a gradual memory loss as well. Okay, so if someone's saying dementia, obviously you need to know that it's gradual. It's not a very sudden memory loss. If it's a sudden memory loss, you want to think about some other causes. Okay, and obviously you will have dysnomia that I already spoke about, that nominal aphasia, comprehension, all of that is probably better. Also, you will have visuospatial defect. Visuospatial defect is usually of the temporal lobe, and you will have apraxia, agnosia, and similar symptoms. And obviously you would have prefrontal cortex lesions if it progresses. Prefrontal lesion in case it. How do you want to diagnose this? You want to diagnose this by a PET scan. You want to do a PET scan, okay? And obviously you can do EEG, and you want to check your CSF levels for A beta 42. When you check for a CSF level of A beta 42, in the CSF your A beta 42 is going to be really low. Also at the same time you will have increased amount of phosphorylated tau in your CSF. Why will you have A beta 42 less? Because all of them are deposited in the CNS gray matter, but at the same time we should white matter. But at the same time you will also know that there'll be increased phosphorylated tau proteins because of probably atrophy of the neurons. Now that is Alzheimer's for us. Next, let's get directly, or if you want to know also, the treatment of Alzheimer's is very important, is tacrine, which is now not given because of hepatotoxicity, galantamine, and we have donepezil. Next coming, we have a very important disease called as another tauopathy, which is PIC, or frontotemporal dementia. It's again a hyperphosphorylated tau proteinopathy. Okay, and what happens is that frontotemporal cortex is associated first, so therefore definitely it's associated with frontotemporal. It's seen in 40 to 70 years individuals, so it can actually be seen in the elderly. And a very important gene is involved, which is your MAPT gene. Okay, how does this entire start? It starts with the atrophy. Okay, it starts with the atrophy of what? It starts with the atrophy of the frontotemporal cortex. So first of all, you will have your behavioral abnormalities also, and you would also have your frontotemporal dementia. Okay, so you will have impaired planning, because we all know that prefrontal cortex is associated with planning, with cognition, with cognition as well, but with recall, more of recall, with entire emotional stability as well. So impairment of memory, impairment of your entire planning, your emotional status, your learning, emotional status. Your learning curve is also misplaced. Your language, if your Broca's are affected, you will have transcortical motor aphasia. Basically that's non-fluent comprehensive, repetitive aphasia. What I mean by transcortical, non-fluent, comprehensive, repetitive aphasia, it sounds really big, but it's basically very simple, is that the patient has speaking something that's non-fluent. That means that the patient is not going to be able to speak a clear-cut sentence. For instance, if I say that the drawing that I'm making is of a green apple, let's say that. Okay, so I'll say that this particular drawing that I'm illustrating is of a green apple. A patient who has a transcortical motor aphasia is going to say the same in this format. Okay, green eye drawing apple D, something like this, which is non-fluent. Obviously, he can comprehend what I am saying because the Wernicke's areas is perfectly fine, and repetitive is also okay because the Broca's areas also seems perfect. But the connection fibers and the other fibers in the frontal lobe is probably involved, which is why there's also transcortical motor aphasia, and this progresses very rapidly. So this is about Lewy body. Frontotemporal disease or Pick's disease. And next, let's talk about a very important disease. And because we want to complete this entire lecture in 20 minutes, we need to wrap up on DLB, diffuse Lewy's body. And as I've said, it's a alpha synucleopathy. And alpha synucleopathy, that means that it could, even a Parkinson is a very strong alpha synucleopathy. So very important is that there is alpha synuclein in the HNO, which is seen as limbic as Lewy body. And where are they? They are in the basal ganglia. Very, very important. Basal ganglia, substantia nigra, brainstem, limbic cortex, all of these areas. And what is very important to understand is that alpha synucleopathy, what do they actually show? They have REM features, they have hallucinations, they have, obviously, very importantly, your autonomic nervous system features like erectile dysfunction. And very important to know is that when you see hallucinations and you might just give an atypical antipsychotic, it might actually worsen it, because atypical antipsychotics, they work as D2 inhibitors. But an alpha synucleopathy like LBD, definitely Lewy body dementia, also shows features of Parkinsonism. And when they show features of Parkinsonism, motor Parkinsonism, okay, so this is very important, and that is to do with DLB. Now let's talk about vascular dementia. Vascular dementia is the last dementia that we have, which is the second most common kind of dementia. The vascular dementia is associated with blood vessels. Now if there is, let's say, a large blood vessel, if there's a large blood vessel or a small blood vessel, if there's a large blood vessel stroke, okay, it leads to a cortical dementia. But if there's a small blood vessel, it's more of the lacunar infarcts, or why they involve the white matter of, obviously, the subcortical ganglions, the subcortical ganglions and nuclei. So you have stroke that is of the cortical aspect, and then we have the subcortical. Obviously, there's going to be a stepwise deterioration of the entire vascular dementia. For instance, obviously, you're going to involve the prefrontal cortex. You will have loss of executive function, then you would have loss of frontal cortex, and then the parietal cortex. So first you would start with prefrontal, you would have loss of executive function, then he would become a frontal cortex associated, and then parietal. See, there is no particular rule when it comes to vascular dementia, but definitely you should remember that there is going to be stepwise decline. Okay, stepwise. It's going to be stepwise. Very important to note. It's going to be stepwise, and it could also be fluctuating, a little bit of fluctuating as well. When it comes to the smaller vessels, that's the subcortical, they are micro infarcts, and they are called Binswanger disease. And this is another very important disease that we have, okay, and it is associated with palsies of the neurons and nerve bodies of the subcortex, that is of the basal ganglia, the medulla, the pons, the various cranial nuclei as such. So there's going to be a lot of symptoms, but we are associated with dementia. So the point I'm trying to prove is that there could be dementia as out here as well. NPH is something, one of the last diseases that I want to cover, the smaller ones, is NPH, normal pressure hydrocephalus, okay? Normal pressure Hydrocephalus. Hydrocephalus is basically increase in CSF, and this increase in CSF is in the ventricular system. Why this is occurring? Because decreased absorption, and because the ventricular system CSF is increased, there's going to be compression of the cerebral lobes. Okay, so there's going to be compression of the cerebral lobes, and when there's compression of the cerebral lobes, there can be dementia. That's all. That's about it. Also, along with that, there could be a lot of ataxia. There could be obviously certain amount of ANS symptoms, UNS, urinary incontinence as such. But dementia is the main symptom that we are looking at out here. Correct. And last but not the least, we have the prion disease. The prion disease, the most fatal disease. It's called Creutzfeldt-Jakob disease. Prions or PRP, they are usually cleared out. Okay, they are cleared out. But what happens is that they sometimes become resistant to proteases and they become PRPS. They become beta sheets of PRPS. These are the proteins, prions, not proteins, but prions. Okay. So what about these prions? Well, are they what are they? Well, they are proteins which are infectious and they lack nucleic acid. So they are basically proteins. Now, when these get deposited in the brain, they cause dementia. Plus, they cause myoclonus. And that's the only feature that you need to remember. Dementia with myoclonus. Someone tells you dementia with myoclonus, straight up go for prions. With bad prognosis, straight up go for prions. And they'll obviously put along with the entire thing that the cortex is more spongiform. Spongiform cortex. MRI shows ribbon-shaped hyperintensity on MRI. Just go for it. So that is the various dementias that we have. Obviously, another important point that I would make before I leave, because we have some time, is the Parkinson disease associated dementia. Well, Parkinson disease, we all know that Parkinson disease is an alpha-synucleinopathy as well. Alright, it is another very important alpha-synucleinopathy. And there is alpha-synuclein that is associated with Lewy bodies in the basal ganglia, loss of dopaminergic neurons. Also, there's going to be tremors, there's going to be rigidity, there's going to be akinesia, shuffling gait, okay, festigating gait, okay, postural instability, all of these, small handwriting, micrographia. So micrographia, this is how micrographia would look like. All of these would be definitely there, but obviously as a late finding, dementia. So now you would wonder that there was another very important disease that we studied, which is also another alpha-synucleinopathy. Alpha-synucleinopathy was that there was Lewy body dementia. So Lewy body dementia is associated with dementia plus hallucination, and later you might see akinesia, rigidity, festigating gait, micrographia, shuffling gait, etc. So that's the only difference between Parkinson disease dementia and Lewy body dementia. So I guess we've covered most of the types of dementia. We've also covered Parkinson disease, or as an overview. Definitely we can do a video of Parkinson disease as the complete disease and in much more detail. But for now, I guess this is it. Thank you very much.